So now coming to the management of systemic hypertension, I'm seeing a lot of ticks and something on the screen. I don't know what's happening. Okay. So coming to let's have a quick recap of what we had around 2-3 weeks back. So the definition of hypertension keeps on changing between different professional bodies. But what is universally agreed that a blood pressure threshold of 140/90, a sustained blood pressure of more than 140/90 is the treatment target for hypertension. And again, this blood pressure has to be measured in the healthcare setting, even though ambulatory blood pressure and home-based blood pressure monitoring is used increasingly, maybe because these techniques are not really widely available. The decision to classify someone as having hypertension and the decision to start treatment is based on office blood pressure measurements. And suppose if the systolic and diastolic blood pressure falls in two different categories, then consider the highest category, whichever is there, either systolic or diastolic. And again, I'm seeing a lot of tick marks and some blue line on the screen. Is there any way that it can be removed? I'm seeing a lot of green tick marks that keeps on appearing in my screen. So it's not from my system. I think actually, and there's a blue line also. Oh, okay. Because that keeps on appearing and it's a little bit distracting. So let us actually start with the way the office blood pressure measurement needs to be done. And this is a place where actually we go really, really wrong many times. And I understand that, especially in a busy primary care setting, sometimes these things actually might not be feasible, but at least actually start trying to implement these things. So the first and foremost, the patient should be sufficiently rested before the blood pressure measurement, and they should not take any caffeine. They should not be moving around. They should be comfortably seated in a chair at least 30 minutes before the measurement. And the blood pressure measurement should be done by a validated device, and we have to use a correct size cuff. And the patient's arm should be reported at the heart level, and the patient should be sitting relaxed in a chair with the feet on floor, and it should be insisted that the patient should not cross the legs in between. The back should be supported, and again, the patient has to stay in the chair for around 5 minutes. And then only go ahead with the blood pressure measurement. And you're not supposed to talk with the patient during the blood pressure measurement. Neither the patient is supposed to talk to you. And it has to be done in a temperature controlled room. That's probably very difficult in our situation. But fortunately, this probably might be an issue in areas where actually it's very cold, because the cold weather tends to increase the sympathetic activity, and probably blood pressures measured in the cooler months probably might be slightly higher compared to the summer months. It might not be a problem in a tropical country like ours. Probably the only other extreme we are going to see summer, because of the extreme exhaustion and humidity, probably patient might be in some sort of a little bit of a physical distress. That's the other extreme which we are going to see. And we have to take more than one measurement. And again, depending on the various professional bodies, the number of measurements varies from 2 to 3. ACC/AHA recommends 2 measurements at least 1 minute apart, and European Society of Cardiology recommends 3 measurements, again 2 minutes apart. And again, we have to measure in the other arm also after a 1 minute gap. And during the first measurement, during the first visit, the first documentation, measure in the opposite arm. And subsequently, when the patient comes for next visit, you take measurements from whichever arm shows a higher blood pressure. And again, another thing we need to do in the first visit is look for presence of orthostatic hypertension. And thereafter, once we start on antihypertensive therapy, if the patient is complaining of any symptoms suggestive of orthostatic hypertension, again, we need to check. So orthostatic hypertension, again, to demonstrate orthostatic hypertension, the patient has to be in supine position at least for 5 minutes. Then after that, instruct the patient to sit up, and we have to measure at 1 minute and 3 minutes. So either an abnormal reading at 1 minute or 3 minutes or both is diagnostic of orthostatic hypertension. Look for a 20 millimeter fall in mercury pressure for systolic and 10 millimeter fall for diastolic. And once actually we get, let's say, a scenario, a patient comes to us and we are having a blood pressure measurement documented as 141 by 92 or something. Do not jump and label the patient as hypertension, because at least 25 or 30% of those hypertensions we document like that. Actually, they might be having a white coat effect or a white coat hypertension. So it's always recommended to do an out of the office blood pressure measurements, ambulatory blood pressure measurement if feasible, but if that is not feasible, go for a home blood pressure measurement. And the crux of the issue is, unless the patient is having a symptom and a hypertensive organ damage symptom, we have to document hypertension multiple times before embarking on treatment. So ABPM is a very useful tool, but not very widely available, and it's a little bit costly also for the time being, but it'll give us a very useful information. Apart from white coat hypertension, it gives us very useful information about the dipping status, about the early morning surge pattern and the blood pressure variability and all. So coming to, once actually you confirm hypertension by multiple measurements, I'm coming to how frequently the next measurement is needed and all. Once we make a diagnosis of hypertension, we have to do the basic minimum investigations. These are the investigations that should be done in all patients. A complete blood count should be done, serum electrolyte, which includes sodium, potassium, and calcium, a lipid profile, and a serum creatinine with estimation of GFR. We don't have a population validated equation in the Indian population, so we have to use a 2021 CKD EPI creatinine equation, and either a fasting blood glucose values or hemoglobin A1C, then thyroid stimulating hormone, urine analysis, urine albumin creatinine ratio if feasible, but suppose if that is not feasible, at least a urine protein to creatinine ratio should be done, and an ECG. And always look for secondary causes of hypertension. There are certain secondary causes which are fairly common, and that should be looked in almost everyone that comes to you. So one of the most common but underrated cause of secondary hypertension is obstructive sleep apnea. So always ask symptoms of obstructive sleep apnea, and if obstructive sleep apnea is there, the hypertension, unless there's a lot of background interference. Can the audio be muted? I request all to mute the audio, please. Yeah. So obstructive sleep apnea is a fairly common cause. It's seen in 25 to 30, especially with the modern day increase in obesity and all, the percentages might be even higher. So if the patient is having hypertension and the reason is obstructive sleep apnea, unless you tackle the obstructive sleep apnea, your hypertension is not going to come down. So if we don't figure out this on time, we will be escalating the antihypertensive, and the patient is going to suffer from the adverse effects of the antihypertensive. At the same time, the blood pressure is not being controlled. And CKD, again, actually, like in certain areas, 14% is considered to be the global prevalence, including all stages of CKD. But especially in certain pockets of India, CKD is even much more rampant, and the prevalence might definitely more than 15 or 20%. The drug abuse and alcohol abuse is something which always we should ask. The other common cause where there's a lot of controversy is screening for primary aldosteronism. Many of the primary aldosteronism will not be diagnosed, and there is a fair chance that it might be misdiagnosed as essential hypertension. And the treatment in primary aldosteronism is, it may not respond to the usual antihypertensive, but a very minimal dose of a mineralocorticoid receptor blocker, it should respond. So this is a controversial issue where every patient should be screened for primary hyperaldosteronism. So the European Society of Cardiology says that all patients at the diagnosis of hypertension should be screened, whereas ACC-AHI has a slightly different take. So they are asking to screen if the patient has any hypokalemia, or if the patient has any resistant hypertension, or anything which makes you to suspect hypertension. Suspect a secondary hypertension. And again, renovascular, especially with in the background of atherosclerotic disease elsewhere. For example, somebody having a coronary artery disease, there is a fair chance that the renal vessels also might be occluded by the same atheromatous process. So in selected individuals, we will have to see whether there's any renovascular hypertension. And the bruit over the lumbar area, that can be exceedingly unreliable, and especially it's very difficult to here in obese individuals. So usually an asymmetry in the kidney size. Suppose if you are doing again, ultrasound is not really mandatory for the primary investigation. That only needs to be done in selected group of persons only. But if your ultrasound shows a size difference of around 1 centimeter between the two kidneys, then that's a scenario where you need to think of a renovascular hypertension. The other scenario that gives us a clue that it's a renovascular hypertension is starting the AC inhibitor and the patient develops worsening of creatinine. Usually, when we start on AC inhibitors, around 30% rise of creatinine can happen. That's because AC inhibitors works by altering the glomerular hemodynamics. So that is perfectly normal. And if actually the patient goes in for a more than anticipated rise in creatinine, or sometimes very tight bilateral renal artery stenosis, the patient goes in for kidney failure also. So such scenarios, we'll have to think of a renovascular disease. So the other thing is there are two parameters on which we decide to treat the hypertension. So one is the blood pressure per se, the second is the cardiovascular risk. So there are certain basic investigations we need to do to assess the cardiovascular risk. So one is a GFR assessment based on serum creatinine and a urine albumin creatinine ratio. If that's not feasible, get a protein creatinine ratio. We need to get an ECG to see for a left ventricular hypertrophy. And the remaining, we have to see the condition of the vessels also. But usually, like most of the time, a carotid or a femoral ultrasound might be needed. Again, that's not mandatory to be done in all individuals. If the patient has significant history of atherosclerotic vascular disease, probably such a candidate might be a good person for whom we have to use the carotid or femoral ultrasound for the narrowing and the plaques. And if facilities exist, we can do a pulse wave velocity or a cardiac CT. And if physical examination is abnormal, then probably we can further do investigations like echocardiogram and cardiac biomarkers. Again, this is optional, like the carotid and femoral ultrasound and pulse wave velocities. Now, the primary aim for treatment of hypertension is to reduce the risk of cardiovascular outcomes. So, you can have uncomplicated hypertension, which means the patient has an elevated blood pressure, but there is no hypertension mediated organ damage. There is no cardiovascular disease. There might be milder degrees of CKD, 1 or 2, because there is an age-related decline also. And usually GFR more than 60 ml, it doesn't really increase the risk manifold provided the patient doesn't really have any proteinuria. So then the other group of patients is those who are having hypertension mediated organ damage, CKD stage 3, or those who are diabetic. And the highest risk is those for patients with established cardiovascular disease and advanced CKD. So now coming to, let us say we have a patient with just hypertension, normal cholesterol, normal GFR, a non-smoker, and not a diabetic, the 10-year risk for an adverse cardiovascular event is going to be less than 5%. Now, let us say the same patient, if we go to this side, let's say the same patient with hyperlipidemia, with a low HDL cholesterol, with a low GFR, and if the patient smokes and the patient is having a diabetes, the 10-year risk of having a cardiovascular event, even when the blood pressure is at 110 millimeters of mercury, is going to be somewhere around 20%. That is actually a huge risk. So basically, the primary aim of the treatment is to reduce the risk of cardiovascular outcomes. Now, again, coming back to confirming hypertension, a random office measurement more than 140/90 or 130/80 if we are following the ACC/AHA guidelines, but that does not constitute, that's not sufficient enough to make a diagnosis of hypertension. We have to exclude white coat hypertension by ambulatory blood pressure measurement or home-based BP measurements. We had discussed in detail regarding the home-based BP measurements in the previous section. So now let's say another scenario, if the patient comes with a blood pressure of more than 160 to 100, but less than 180. We have to confirm as early as possible, maybe days or weeks within 1 month. And if the person presents with a blood pressure of 180 to 100, the diastolic blood pressure is actually like a little bit of an area where there is not much of consensus is there. If we look at certain guidelines, they give 110, 120 and all. Usually a systolic blood pressure of more than 180, you have to exclude a hypertensive emergency. Now, if the patient comes with a blood pressure of more than 180 by 100, there's no target organ damage, there is no previous history of hypertension. Such patients probably there is no emergency indication to start pharmacotherapy. They can be left, but with an instruction to come quickly within a week or so. Meanwhile, if we have the facility, we can do the home BP measurements. But this type of patients with a blood pressure of more than 180 over 100 without any target damage, we cannot leave them like that. They have to come back as early as possible. And now the other scenario, let's say the patient is falling under the elevated blood pressure category. So I already told 140 by 90 is the threshold at which we decide to start on blood pressure lowering therapy. Now there is another group of individuals whose blood pressure is not really normal, but it neither actually fits into the definition of hypertension, but they are in that elevated blood pressure category. There, suppose actually if they have any highest cardiovascular conditions, there are various scoring systems used for that. I will be coming to that in the next slide. So those type of patients, we have to confirm BP, preferably with either home or ambulatory blood pressure measurements. Suppose if they don't have any other cardiovascular risk, probably we will still give the lifestyle advices because that's going to prevent the development of hypertension. And those who are in the elevated blood pressure group, if they follow a healthy lifestyle, there is a fair chance that they might regress into normotension. And this type of patients give the lifestyle advices and ask them to come back at least in another 1 year. And any adult over the age of 40 years, even if the blood pressure is normal, should have an annual blood pressure assessment. And under 40 years, it should be every 3 years. And if we are making, I told you all the definitions are currently based on office blood pressure measurement. Now, if we are sending the patient home for a home blood pressure measurement and an ambulatory blood pressure measurement, we need to keep in mind that the threshold for diagnosing hypertension is slightly different and lower compared to the office blood pressures. So usually the ambulatory blood pressure measurement, if we take a daytime average, we take usually normal as 120 and diastolic as 70. But for hypertension, instead of 140 by 90, we are going to take 135 by 85. And this is the daytime blood pressure. We will have to keep the targets even lower, another 5 millimeter lower if we are taking the 24-hour average. Similarly, for home blood pressure monitoring also, we don't take the nighttime. Obviously, that's not going to be possible. So if a person having an office blood pressure of 140 by 90, and if the home blood pressure is more than 135 by 85, that's sufficient to diagnose hypertension. So what you need to keep in mind is a 5 millimeter pressure, systolic and diastolic, lower for home blood pressure based measurements. ABPM 24-hour measurement, if we are averaging, it's going to be 10 millimeter lower, and a daytime measurement is same as the home blood pressure targets. And the decision to treat is based on the cardiovascular risk and not blood pressure alone. Again, if the office blood pressure is consistently more than 140 by 90, and if we document a blood pressure of 135 by 85 with out of the office measurements, that type of patients will treat. But there is a group of patients who doesn't cross 140 by 90, who might be having slightly lower pressures, but such patients we decide to treat based on the cardiovascular risk. For example, a patient with a cardiovascular disease, a patient with CKD, or a patient with a diabetes, we initiate treatment at a slightly lower threshold, and the targets also, the blood pressure targets we want to reduce with the lifestyle and pharmacotherapy is going to be lower. And most of the scenarios, when they have cardiovascular cardiovascular disease, CKD, and diabetes mellitus, we really don't give them a very long time. For example, someone comes with a BP of 140 by 90, absolutely no risk factors. It's perfectly okay to keep the patient on lifestyle modifications for a period of 3 to 6 months. On the other side, somebody with a CKD comes with a blood pressure of 140 by 90, we reconfirm it as early as possible and we start on pharmacotherapy. So patients with the high cardiovascular risk factors, probably a wait and watch approach. We need to act a little bit faster. It doesn't mean that we have to start acting on the day of the hospital visit, but only thing is the time we spend on not allotting them to pharmacotherapy is going to be slightly lower. And coming to assessing the cardiovascular risk, if you have diabetes, if you have a previous cardiovascular disease like a myocardial infarction, angina, or a stroke, or any other atherosclerotic vascular disease involving any territory, or if you have CKD, then you are going to be on the highest risk. But sometimes there might be certain patients who doesn't have any of these overt diseases, but they will be having dyslipidemia, they'll be smokers and all. These are parameters that keeps on increasing your cardiovascular risk. So European Society of Cardiology has come with a calculator called SCORE calculator. So it's SCORE 2 for outpatient, and then there is another SCORE calculator which is to be specifically used in diabetic individuals. So this basically is a calculator that yields you what is your risk of developing adverse cardiovascular event in the next 10 years. So this incorporates the gender, the blood pressure, age, HDL cholesterol, non-HDL cholesterol, and smoking status. And if you are in the green zone, your risk is very low. That's less than 2.5, which is somewhat similar to that of the general population. And yellow is kind of intermediate, and red is basically the highest risk, which means in the subsequent 10 years, your chances of developing adverse cardiovascular event is more than 7.5%. Similarly, ACC-AHA has given yet another calculator which is almost on the similar lines, but only thing is that this calculator called Prevent calculator incorporates the diabetic status also. And again, there has been a lot of comparative studies between SCORE versus Prevent2. And if according to the recent published data, Prevent2 probably is slightly better in predicting the adverse cardiovascular risk. Because the calculator uses a different mathematical model, SCORE2 actually, the 10-year risk, more than 10% is considered as the highest risk, whereas in SCORE2 calculator, it is 7.5. And this ACC-AHA needs a lot of other input parameters. What I have shown is a simplified version. So if that's not available, we can use the SCORE2 calculator. But again, the problem with all this calculator is these are not validated in South Asian populations, and South Asian ancestry is considered as a major risk factor. So we really don't have a calculator that can be confidently used. So it's always possible that we might end up underdiagnosing because of the ethnicity. And again, this was what I was telling. Even if you are using the calculators, I do not recommend using the calculators because of the issue of it not being validated in the Indian population. And again, even if you are using the calculator and the 10-year risk is lower, you have to see some other factors that actually act as a risk modifiers. One is a South Asian ethnicity. Then always ask for premature history of atherosclerotic vascular disease in the family, low socioeconomic status, autoinflammatory diseases. For example, someone with treated lupus. Even after treated lupus, the patient might not be on immunosuppression. That patient is considered as having a highest cardiovascular risk. Then mental health issues and HIV status. Similarly, there are certain things which are more common in women, and whether hypertension mediated damage is more common in women, that's again a controversial topic. There is some data telling that both men and women are at equal risk, and on the other side, there's equal amount of data showing that women might be at slightly higher risk. And always ask for history of gestational diabetes, hypertension, preeclampsia, history of preterm delivery, one more stillbirth, and recurrent miscarriage, because pregnancy acts as a stress test for the cardiovascular system and the kidneys. So If you are able to have an uneventful pregnancy, probably that is a kind of a guarantee that you have an intact endothelial function. On the other side, any of these complications of diabetes basically means that your body is not able to handle the stress. You have an endothelial dysfunction, which probably might manifest in the subsequent years to come. So coming to the hypertension, what we need to keep in mind is hypertension is a lifestyle disease. There are primitive societies who never have hypertension, who follow a very traditional lifestyle. So it's a lifestyle disease, and unless you change your lifestyle, pharmacotherapy is important, but that's not the only thing. Your lifestyle modifications are going to be equally or maybe even slightly more important compared to the pharmacotherapy. And patient has to dedicate some time for self-care. It's a multidisciplinary disease because, for example, all of them needs dietary counseling. And many of us sitting in our busy OPDs, what we are going to tell them? We ask them, you take a less amount of salt. And how many times we bother to tell them how much salt they can take? Many times we might not be able to do so. But these are certain things which can be easily and beautifully done by a paramedical team. If you have a dietitian or a social worker, probably we can make use of, or even a trained staff nurse sometimes. And these are things which can be addressed in the form of group sessions, because one-to-one sessions, they are always the best, but most of the time in any system with a very busy, very large footfalls and all, that's not going to be possible. So maybe we can try putting as a group sessions and all. And even if we repeatedly tell the same thing, the chance that somebody will follow these things when we tell these things repeatedly is fairly high. So even if 20 or 25% of the people adhere to our instruction, I would say that that should be considered as something really big. Now, suppose if the patient doesn't have any high risk, they just have an elevated blood pressure, no diabetes, no stroke, no cardiovascular disease, no kidney disease. Still, we have to, first actually we confirm the hypertension. We can put them on a short lifestyle management, maybe 3 months or 6 months, or certain cases, probably a little more longer. But if repeatedly, even after lifestyle intervention, this patient has a blood pressure of more than 140/90, that's an office blood pressure. If we are taking the decision based on home blood pressure, we have to use a lower threshold. We need to treat these patients, because treating these patients with BP over 140/90 without any of the adverse risk factors, even without a low cardiovascular risk, there is a 10% absolute risk, 10% relative risk reduction from cardiovascular disease. Now the patient has cardiovascular disease. There is a coronary artery disease, stroke, or heart failure. There, the threshold for treatment is 130/80. If the patient has a blood, normally we treat a low risk individual when the blood pressure is consistently more than 140/90. Whereas if the patient has a clinical cardiovascular disease, we start the treatment when the patient is having a blood pressure more than 130/80. Similarly, if the patient has a diabetes CKD, or using any of the scoring system, if the score or the prevent score shows us a very high risk of adverse cardiovascular outcomes in the next 10 years, again, we keep the threshold for treatment as 130/80. And what should we do to those individuals who have the elevated blood pressure? Again, we will actually put them on lifestyle management. And again, it is also recommended that after 3 to 6 months of a lifestyle changes, if this patient's blood pressure remains persistently more than 130/80, it is better to treat. This applies to individuals over the age of 30. There is no recommendation for individuals under the age of 30 because of the non-representation in many of the clinical trials. Now, coming to the treatment target, there's a little bit of a difference between the treatment targets by different professional bodies. So, European Society of Cardiology, they want the blood pressure to be maintained between 120 to 129 and a diastolic blood pressure to be maintained between 70 to 79. And allowances are given in individuals if they have orthostatic hypotension or if they are very elderly, over the age of 85. There's no target diastolic blood pressure recommended in those age, but try to keep the systolic blood pressure around 140. And again, 140/90 in case of severe frailty and those with a limited lifespan. And ACC-AHA, the guidelines has come in 2025, 1 year later after the ESC guidelines. So by the time a few more trials also, this is largely based on the sprint trial, but sprint trial again showed that blood pressure of less than 120 is beneficial, but that was probably the only trial available when the ESC guidelines were published. And subsequently, 2025, we have actually a few more trials. The BP trial in diabetes, then there is a ESPRIT trial in Asian population, then there is a STEP trial in elderly, and all has actually demonstrated the safety of keeping a target of a systolic blood pressure less than 120. So ACC-AHA recommends to, if possible, try to keep it less than 120 in those patients without the risk, and it should be 120, less than 120 in patients with the cardiovascular risk, CKD, and diabetes. So 130 if the patient does not have any risk, preferably with a recommendation to bring it further down to 120. And if the patient is having any other additional risk factors, it has to be kept to less than 120. Diastolic blood pressure is same as the European Society of Cardiology. And again, the recent trials on the target blood pressure, they were all looking at the systolic blood pressure part and not the diastolic blood pressure. So basically for diastolic blood pressure, the evidence 70 to 79 or even lower, we don't really know. The evidence is not as strong, but there is good quality evidence to keep the blood pressure less than 120. But this should not be aggressively pursued in someone who is having orthostatic hypotension. We will not be able to attain 120 in certain individuals. For those individuals, keep at the lowest blood pressure that keeps orthostatic hypotension away. Now, lifestyle changes, the crux of the issue is you need to stay active. You have to do 150 minutes of a moderate intensity exercise. A moderate intensity exercise is basically you're going to do something around an activity around 50 to 70% of the maximal heart rate. Maximal heart rate usually is 220 minus your age. For example, somebody who is 40-year-old, the maximal heart rate probably is going to be 180. And of this 70% of 180, so that probably is coming to somewhere around 130 to 140. So if your heart rate doesn't exceed that, that's considered as a moderate intensity. So the best way to know, even if you don't have a smartwatch, is while doing the activity, we will not be able to see, but we'll be able to tell a small sentence. But on the other side, continuous speech, like the way I'm talking, if you're doing a moderate intensity activity, you will not be able to do. You will be stopping in between one or two sentences. Whereas on the other side, vigorous intensity exercise, you are increasing your heart rate up to 77 to 93% of your maximum heart rate. So that actually basically means that you will be able to speak only in monosyllables. You won't be able to utter a sentence. So people who are relatively sedentary, do not actually advise them to jump into vigorous intensity aerobic activities. You will have to see the cardiovascular fitness, and especially someone with a prior history of cardiac disease or a cardiovascular disease, a proper cardiac evaluation should be done. Whereas somebody, even if actually they don't have any risk factors, it's always better to start with a lower intensity and gradually build up rather than going to the gym and doing some exercise which they are not really accustomed to. Then it's always recommended to do some resistance training along with the aerobic activities. So it's recommended to do isometric exercises. You don't really need to do very long isometric exercises. An isometric hold exercise, here what you're seeing is a plank, then probably the other thing like a hand grip, then a wall sit. All these things can be done. There are a lot of isometric hold exercises. You need to do 3 to 4 sets with a 1 to 2 minutes hold time. It's not easy. So probably when people start, you can ask them to start with a 15 or 20-second hold time and gradually build up, and you can increase the hold time to 1 to 2. And you can also do the dynamic resistance exercises. If you are primarily looking on aerobic activities, this is actually supplementary. You can do 2 to 3 sets of 10 to 15 reps each. But instead of the aerobic activity, the dynamic resistance, you can primarily rely on dynamic resistance exercises also. But again, someone who is actually very sedentary, starting off dynamic resistance exercises is going to be a problem, and it is always better done under the observation of a trainer, because this exercises include a lot of movement, and probably an injury is something which we don't really want at this point. Now, weight loss is extremely important. So, weight loss of 5% of the body weight is associated with a systolic and diastolic blood pressure reduction of around 4 to 3 millimeters of mercury. And in addition to the blood pressure control, you'll have better glucose and lipid metabolism, and it's also associated with a reduced all-cause mortality. And we can have a heart healthy diet. DASH diet is what is advised, but there are many other heart healthy diets like Mediterranean diets and all. So the only thing is advise a diet that's going to be feasible. So the DASH diet is quite easy to incorporate into any dietary practices. So basically, it relies on a lot of fruits and vegetables to give potassium. In the last session, I told potassium, when you take more potassium, that's something that can drive the sodium out of your body. And potassium also has a little bit of a vasodilatory effect. And whole grains, low dairy fat, lean proteins, healthy fats, and limit salt, trans fat, and processed food. Sodium needs to be reduced to 2000 milligrams. So this is around 5 grams of sodium chloride, which is 1 level teaspoon. So this is the advice you need to give to the patient. The best case scenario is prepare everything without food. Without sodium, without salt. Then take 1 level teaspoon. Take 1 teaspoon, then take a scoop of salt, level it. And what is remaining probably will be around 4.5 to 5 grams of sodium chloride, which approximately will be converting to around 2 gram of sodium. Now, don't get actually frightened by the DASH diet and all. It's very well possible to have a DASH diet plan with the usual staple Kerala food. But only one major problem is, if you see the previous slide in the DASH diet, it's fashioned in such a way that around 50% of the calories are from carbohydrates. But this is a big problem in our state, not in our state, in generally in India. We have a huge reliance on carbohydrates, and National Nutritional Surveys and all have shown that around 65 to 70% of the calories we eat in a day is derived from carbohydrates, and that's not something which we really want. So the DASH diet, let's see how actually we can advise on a DASH diet. So DASH diet, basically we have to take whole grains, 6 to 8 servings a day, and 1 serving is considered as a half cup, and 1 serving as a half cup of cooked rice is going to be somewhere around 100 to 120 calorie per day. So probably somebody who needs 2000 calories, mind you, again, if you are older or if you are 40 plus and if you have a sedentary life, probably you don't need 2000 calories. It might be slightly lower, even lower for the females. For example, someone of my age and my height probably needs 1600 calories for the usual day-to-day activity. We can actually keep it closer to 6. If it is 2000, we can keep it 8, and less than 1500 calorie diets are definitely not feasible, and people will be like a kind of yeah. So now let's say in 2 idlis, the usual average sized idlis we make at home has around 100 calories. So now if we take 4 idlis for breakfast, that's going to take that's considered as 2 servings. And dosha, again, dosha can be somewhere around 70 to 80 to 120 or 150 depending on the size. So probably 2 to 1.5 doshas might be an okay carbohydrate source. On the other side, idiyappam, again, the small idiyappam we have, 2 of them will give around 100 to 120 calories. So basically, and again, appam also same thing. Appam is slightly more calorie dense, and appam and puttu, because it's like mostly rice, it's going to be calorie dense, and each one will have around 80 to 100 calories. So this is the rule of thumb actually we need to tell the patients. They need to reduce the amount of carbohydrate calories. So And on the same side, they need to increase the protein content. So, if actually we stick on to limiting the carbohydrate and slightly increase, I'm not asking for a high protein diet. So we are supposed to take around 1 milligram per kilogram body weight of protein. And many of the Indian diet, especially when they eat a vegetarian diet, most of the time we end up eating a 60 kg adult probably might need 55 to 60 calories, and most of the average Indian eats around 35 to 40. Maybe Kerala, probably we have more access to fish, it might be slightly higher, but still most of the time when we track the diet, most of the time we end up eating way much lesser protein than what is recommended, and we have this tendency for the carbohydrates to overshoot, and that's not something which is great for weight loss, and that's not something that's going to help with you with your hypertension. And the other thing which we need to limit is the amount of rice we take for lunch. So 1 cup cooked rice is going to be 2 servings. So basically, if you have eaten 4 idlis in the morning, that will constitute 2 servings. And maybe 1.5 cup of rice, that's going to be another 3. So that's 4 plus 3, 2 plus 3 is going to be 5. And if you eat 2 chapatis in the evening, probably that's going to be around 7 servings. So most of the time, the carbohydrate restriction part, that's important, because when we take up more carbohydrates, that's going to increase your weight, that's going to create insulin resistance, and that's going to create a milieu that's very congenial for adverse cardiovascular health. So if you have, I know that many of the primary health centers might not have a dietitian, but basically the best thing that can be done is train some person who is interested, a paramedical staff, and have this type of dietary counseling thing as group sessions. And nowadays, or otherwise, at least even if you can have a dietitian come to your hospital at least once in a week and probably organize some group sessions, that's going to be beneficial, because without changing the lifestyle, there is absolutely no point in increasing the drug. We might end up increasing the drug, but the actual pathology is not taken care of. Then vegetables, it's very easy, 4 to 5 servings. So 1 serving is like half cup of raw or cooked vegetables, and that can be easily done with our diet. And again, fruit is somewhere many of us actually like, we don't really take that much of fruit. So basically, the idea is to take a 1 medium-sized fruit or a half cup of fresh frozen, a cup of fresh frozen fruit with every meal. That would actually be 4 to 5 servings. Then milk again, we end up taking the required amount of milk in the form of milk or either as other milk products. But basically, the major issue, if we want to convert our diet to a heart healthy diet, the most important point is we need to reduce the carbohydrate calories, and we need to ensure that the patient eats sufficient amount of proteins. So most of the time, we are supposed to take 6 1 ounce servings or fewer a day. So basically, that amounts to around 150 to 180 grams of protein, which can be easily taken with, let's say, 1 chicken leg is going to be considered as 3 servings, 1 ayala fish is going to be around 3 servings, and 3 or 4 matti is probably going to be another 3 servings. So the emphasis is, most of the time, Kerala, probably we might be taking around 50 grams of protein, especially if the person is a non-vegetarian. But the emphasis is to be given on the lean meat or fish, plus reduction in the carbohydrate calories. And again, nuts and these are things that needs to be taken 4 to 5 servings in a week. And fats and oil, probably we need not actually take additional fats and oil, because we use this oil for cooking. So you can take like 2 to 3 servings of a day, and 1 serving is considered as 1 teaspoon of vegetable oil. So basically, for a family of 3 people, if you assume that they take 3 servings, each person take 3 servings. So what's needed in a day is around 40 ml of oil. So the best way the oil can be regulated is a family of 3. should not consume anything more than 1.5 or 2 liters of oil in a month. So that's the best way, that's the best advice we can give to the person who cooks the food, that you reduce, ensure that you don't use oil beyond this much point, and avoid sugar, sweets and added sugars as much as possible. 5 servings or fewer in a week, and it should not be the sweetened drinks and all, it should not constitute more than 10% of the calories. So the best is this something called a plate model. Quarter of the plate vegetables and fruit, quarter of the plate protein, and another quarter of the plate whole grains and carbohydrates. So alcohol use needs to be limited. Caffeine intake, probably that doesn't really apply to people who drink the homemade coffee, because 300 milligram per day with the regular coffee we make at home, probably we are not going to reach that until and unless we drink 8 to 10 glasses per day. But those coffees which we get from the cafe coffee day, those type of brewed coffees and all, their caffeine content is very high. It can be 100 to 200 milligram per day. And if the patient is having resistant hypertension, you are not finding any other cause, you have investigated, and if the patient is in the habit of taking coffee, it's better to ask them to stop. Then again, stopping the smoking is important. Avoid the nasal decongestants as much as possible. It's not a very big issue in our place, but if at all somebody is using, limit it to the minimum number of days. Then the other thing is this traditional remedies. Again, the only thing which is probably of a problem here in India is licorice and this ephedra. Ephedra is called as somalata. Mahuang, St. John's wort, and all these are plants which are not available in our region. But suppose if you are in the habit of following some alternate medical practices and all, then these are the things that can actually have a sympathomimetic activity. Then sometimes take a proper drug history. One thing which is very common, especially in patients with the kidney diseases, is an improper prescription of clonidine. The clonidine is a drug that can reduce the blood pressure. On the other side, if we skip a dose, there is a chance that the blood pressure will rebound. And again, at higher doses, it can stimulate the peripheral alpha receptors and can cause vasospasm. Tisanidine is a commonly used muscle relaxant, but unfortunately, it has this property of elevating the blood pressure. Then some of the antidepressants and antipsychotics. If a patient is on antidepressants and antipsychotics, you'll have to consult the psychiatric team to ensure that these things are not going to interfere with the blood pressure control. And many of the oral contraceptive pills can cause hypertension. Cyclosporin, probably that's a different scenario. You are less likely to see anyone who is on cyclosporin in the usual primary and secondary care practice. Then long-term tyrosine kinase inhibitors. Nowadays, actually, there are a lot of tyrosine kinase inhibitors available for the treatment of various malignancies. So they also have this propensity to produce hypertension. Similar thing with anti-VEGF based therapies. So this is the usual range of blood pressure control, which it can be anywhere from 5 millimeters of mercury to 10 millimeters of mercury. And this blood pressure lowering effect is seen in individuals without hypertension as well. Coming to pharmacotherapy, so we can use a thiazide, a long-acting dihydropyridine. So not the short-acting forms of nifedipine, but a long-acting form of nifedipine. Any non-long-acting dihydropyridine calcium channel blocker, AC inhibitor, or ARB. Any drug from these 4 classes can be given as the first-line drug. So usually someone with you can start with the monotherapy, but generally to increase compliance and to provide round-the-clock protection, a combination therapy with a fixed dose combination is recommended. And it can be preferably, it should be given once daily, because multiple doses will be associated with less compliance and there is no specific time. The patient can take it on morning or evening. That's the patient's choice, but being compliant with the medication is more important. And never combine an AC inhibitor with ARB. You can combine AC inhibitor or ARB with any other thiazide or long-acting calcium channel blocker, but not AC inhibitor and ARB. Direct renin inhibitor, it's no longer available, so it also should not be combined. And beta blocker should not be started as a first-line therapy because of the controversial data. So it can be added as an add-on therapy along with any of these first-line agents. For example, you want to start the patient on a dihydropyridine and the blood pressure is not controlled. The next choice obviously can be beta blocker. It need not be thiazide or ACE inhibitor or ARB depending on the situation. And beta blocker, if at all add a cardioselective beta blocker or a vasodilating one. And in isolated systolic hypertension, do not prescribe beta blockers because beta blockers increase the stroke volume. So it might make the isolated systolic hypertension worse. So then again, there are other, while titrating the drugs, there are other drugs with BP lowering properties like angiotensin and neprilysin inhibitor, SGLT2 blockers, GLP-1 receptor agonist, and finerenone. So if the patient is, if the patient is on any of these drugs or if the patient has a clinical indication to start on this drug, allowances should be given for these drugs when you select a second line agent. And these are potential new additions which actually might be available in the next couple of years. There's a dual endothelin A and B receptor blocker. This has cleared the phase 3 trials, but not yet approved. Then there is an aldosterone synthase inhibitor called Braxtostat. Again, phase 3 trials are over. And something which is undergoing phase 3 trial is RNA interference therapy. The drug name is Silbesiran, and it inhibits the hepatic angiotensinogen. So this has shown very promising results in phase 2 trials. And if this comes into market, obviously it's going to be quite costly. The advantage is many of this RNA interference therapy, they can be given as injections and you need not really take it every day. And some of these things, the gap between the two doses can be a couple of months also. Now, hypertension with comorbidities, if the patient has CKD and hypertension, the first line agent has to be ACE inhibitor or ARB. Similarly, if the patient has a diabetes with CKD or a proteinuria more than 30, again, the choice of the drug has to be ACE inhibitor or ARB. So obesity, you can start with other drugs, but if the patient has a BMI more than 27, it is recommended that this patient should be candidates for GLP-1 receptor agonist therapy. And if the BMI is more than 35, probably these are candidates for bariatric surgery. Then heart failure with a reduced ejection fraction, when the patient is in NYHA 2 and 3 symptoms, you can start on a RAS inhibition with ACE inhibitor or ARB or ARNI. Then followed by SGLT blockers, mineralocorticoid receptor blockers, and on the third generation beta blocker. So this is the order in which we need to follow. So if someone has an uncomplicated hypertension, no compelling indications, no diabetes, no heart failure, no obesity, no CKD, no proteinuria, then possibly you are free to select a drug from thiazide or a long-acting calcium channel blocker or an ACE inhibitor. So whatever class of the drug, that doesn't really make any difference. These are the classes. Hypertension with comorbidities, where the choice of the drug matters. Diabetes and CKD, it has to be ACE inhibitor or ARB. Obesity, again, this after lifestyle medications. So along with antihypertensive therapy, you should always try GLP-1 RA. Again, it's costly. I don't know about how many people can afford it because the prices are still, I believe, close to 20,000 or so. And heart failure with a reduced ejection fraction, again, start with ARNI or ACE inhibitor. Now, coming to the management of hypertensive emergencies, there are a lot of confusing terms: hypertensive crisis, hypertensive urgency, malignant hypertension. As of now, almost all these terms are abandoned. Even review articles still continue to use this. So there's a hypertensive emergency, which is associated with a very high blood pressure, defined as a systolic blood pressure of more than 180 and a diastolic blood pressure of more than 110 to 120 with new or worsening target organ damage. That's hypertensive emergency. Somebody has a blood pressure of more than 180 or more than 120, more than 180 over 110 or 120 without any organ damage. This was previously called hypertensive urgency. This is now called as asymptomatic markedly elevated blood pressure. Now, If the patient has a systolic blood pressure of less than 180 and less than a diastolic blood pressure of less than 110, this is simply called as asymptomatic elevated blood pressure. And this is a very fairly common thing seen in the emergency department. And it doesn't mean that all of them needs active treatment. So when in the inpatient setting, there might be a lot of factors other than hypertension that contributes to the elevated blood pressure. So simple things like anxiety, sleep deprivation, acute distress because of pain or something, then the use of BP medicines, BP increasing medications, there might be a lot of things apart from hypertension contributing to the elevated blood pressure. So now when such a patient comes to you, if the systolic blood pressure is less than 180 and diastolic blood pressure is less than 110 to 120, we have to see, for example, somebody comes with severe pain and the blood pressure is elevated. Sometimes giving a medication for pain relief, that actually will bring down the blood pressure. So now see whether there is any cause which is contributing to the blood pressure. And again, look at whether the patient had pre-existing hypertension. If there is a pre-existing hypertension, again, recheck the blood pressure after a couple of hours or so. And probably this is a scenario where actually you can increase the antihypertensive. But again, you have to be very carefully assess the risk and benefits of modifying the antihypertensive therapy. So if you think that the risk outweigh the benefits, probably you can discharge the patient on the same prescription and ask the patient to come back in a week or so. And in the other group of individuals presenting to emergency department without a chronic hypertension and the blood pressure is elevated, but not to a very dangerously elevated levels like 180 or 110, then in those group of patients, especially when they don't have a history of chronic hypertension, the risk might outweigh the benefits of initiating or modifying antihypertensive medication regimen. So here in this group of individuals, ask them to go and come back after some time for a redocumentation of hypertension. You can again ask them to have a home BP measurement done and all. And suppose if the patient has a blood pressure of 180 and a diastolic blood pressure of more than 110 or 120, then these are the patients who we have to look for the target organ damage. And if there is no target organ damage, again we are going to see whether they had a pre-existing hypertension or any other risk factors. If nothing is there, probably we are going to allow that permissive hypertension to be there, but we defer the decision to a subsequent occasion. But if there's any target organ damage, we have to admit and reduce blood pressure. So in an acutely elevated, the other scenario is someone actually comes with a severe headache. By definition, a blood pressure of 180 and severe headache is not considered as organ damage, but sometimes the patient will be very restless. The patient is complaining of severe headache. That's not a patient who should be sent back home. And if there is evidence of organ damage as evidenced by a abnormal neurologic examination, the fundus shows new onset bleeds or the fundus shows papilledema, the patient has any cardiac issues, there is reduced urine output, that's a scenario where we have to urgently reduce the blood pressure by 20 to 25% of the previous value in a matter of 1 or 2 hours. And always use a titrable agent. We don't want any sustained hypertension in this scenario. So use a titrable agent like labetalol, esmolol, nicardipine or nitrates. Sodium nitroprusside, be careful in patients with chronic kidney disease because that nitroprusside has a cyanide thing and the cyanide can accumulate and lead to cyanide toxicity. So if you are not sure, avoid the sodium nitroprusside. And again, I believe it's very difficult to get sodium nitroprusside nowadays. Suppose if the patient has some symptoms, not in a condition to be sent home for a repeat measurement, such type of patients, we can start off with an oral agent. And again, any of the 4 oral agents that we have mentioned previously. And our target is basically to reduce the blood pressure by 25% in the first 24 hours. If we are starting on medication, if you believe that this patient with a blood pressure of more than 180 by 100 has some symptom that's attributable to the hypertension, but there's no previous history of hypertension, you think that basically sending this patient home will be risking his life, Start on oral antihypertensive agents and ask the patient to come back after 24 hours. Now coming to the IV agents, there's no role for sublingual nifedipine. There is no role for oral clonidine for acute reductions in blood pressure. It has to be a titrable agent and it has to be done in the ICU setting. So a few of these agents are probably not available. Enalaprilat is very difficult to get in India. And hydralazine is available. Nitroglycerin is the one which is mostly available to many of us. Labetalol and esmolol are available, but esmolol has a problem. It causes very bradycardia very quick. Whereas on the other side, if given a choice to select between esmolol and labetalol, I would say labetalol is perhaps a little more user friendly, and the esmolol reduces blood pressure immediately. For example, you want a situation like aortic dissection where you want to reduce the blood pressure as quickly as possible. Esmolol is probably the thing which actually in the fastest way compared to labetalol. And hydralazine, one problem with hydralazine is hydralazine mostly is used in obstetric practice. One problem with hydralazine is hydralazine will cause reflex tachycardia. So certain situations that's not really wanted. For example, someone having a coronary artery disease or somebody who is having an aortic dissection. So these are the scenarios where you really don't want this reflex tachycardia. Then sometimes CKD patients putting them on hydralazine can be slightly tricky because they already have anemia, and when the heart rate increases, these patients can develop overt pulmonary edema. Now, aortic dissection is the only situation where we have to reduce the blood pressure to less than 140 in the first hour. Rest everything, the usual principle is 20 to 25 over the first 1 or 2 hours, maintain it for the next 6 hours, and probably from there gradually bring it down. Then in a hemorrhagic stroke, usually it's not recommended to reduce the blood pressure to less than 140 millimeters of mercury. And if the systolic blood pressure is very high, like more than 220 and all, probably a target of 180 might be better. And hypertensive LVF, again, the broad principle is around, like we don't really need 20 to 25, even lower is okay, but give more importance to the symptomatic status of the patient. And again, these are all special circumstances, stroke and TIA. So if the patient is going for thrombolytic therapy, the target is less than 180 to 105. And if the patient is not going for a thrombolytic therapy, probably you go for a slightly lesser targets. Like if the blood pressure to begin with is more than 220 by 110, your aim is to reduce only 15% and not 20 or 25%. And if it is TIA, probably we are going to be a little more intensive. Now, coming to resistant hypertension, resistant hypertension is defined as blood pressure that's not controlled with 3 category of antihypertensive, of which one includes the optimal dose of 3 antihypertensive, of which one is a diuretic. So we have to exclude pseudo resistance with special focus to the adherence of medications, and always use out of the office BP to exclude white coat hypertension. Look at the lifestyle factors, whether the patient is adherent to that or not, and any interfering substances, anything is there, you have to stop it. Maybe one thing which probably is used in many indigenous systems of medicine is licorice. Licorice is basically a mineralocorticoid agonist, and that has hypertensive properties. Then screen for secondary causes of hypertension, especially primary aldosteronism. This is something that can be done in the primary care setting also. You need to look at a renin and aldosterone ratio, and there are various cutoffs mentioned depending on the units of renin and angiotensin, and optimize the medical treatment. And suppose if still actually that patient's hypertension is resistant, then probably that's a time that the patient should be referred to a specialist. So these are the common causes of resistant hypertension, which we can easily tackle. Again, I have told this before. So there are certain scenarios which probably cannot be managed in the primary care. One is a very young onset of hypertension, and by the way, very old age. For example, someone coming with a normal blood pressure and suddenly becoming hypertensive after 60 years. But that's not the usual way the primary hypertension behaves. So such patients, they are very young and very old individuals, and severe hypertension usually will be associated with some secondary causes. Patients with end organ damage, for example, somebody having cardiac failure or somebody having kidney disease, probably sometimes, especially advanced kidney disease, cannot be managed in the primary care setting. And all children with hypertension. Then, based on the ABPM profile, this needs a little bit finer adjustments of the medication and any acute rise. For example, someone who was having a blood pressure of 140 by 90 suddenly comes with a blood pressure of 180 by 90. That's not something that's compatible with the natural history of essential hypertension. The patient might be having something on top of essential hypertension, and hypertension associated with a hypokalemia or metabolic alkalosis, and resistant hypertension. After ruling out all those causes that I have mentioned, still the blood pressure is not elevated, always refer to the next higher center. So that's all for today. I have excluded certain things because a very elaborate discussion on hypertensive emergencies is not going to be possible in a single day. So if there are any questions, I can take up that questions.
Thank you, Dr. Priyamvada. That was an excellent session. Participants can ask your doubts directly or type in the chat box.
So I have focused mainly on what you can do in a resource limited setup, like in a primary care center. I believe most of the people are working in the primary health centers where actually probably advanced testing and all might not be available. So I have just limited my discussion what you can do in the emergency room and what you can do in your outpatient practice.
പാർട്ടിസിപ്പൻസിന് ക്വസ്റ്റ്യൻസ് ഡയറക്റ്റ് ആയിട്ട് ചോദിക്കാം. പാർട്ടിസിപ്പൻസ് അൺമ്യൂട്ട് ചെയ്തിട്ടുണ്ട്, ഡയറക്റ്റ് ചോദിക്കാം, ഇല്ലെങ്കിൽ ക്വസ്റ്റ്യൻസ് ടൈപ്പ് ചെയ്യാം.
Hello.
Hello.
Regarding the use of clonidine in emergency setup.
Clonidine is no longer recommended in emergency use. But the problem is clonidine has this withdrawal. The problem with clonidine is you cannot take it out suddenly. So it might temporarily reduce the blood pressure, but maybe once the half-life is over, that's after 6 to 8 hours, probably you're going to deal with more rebound hypertension. So the other thing is many of the, see, for example, if you're starting on amlodipine, this amlodipine generally will not have a very rapid antihypertensive effect. It takes time. And once actually the antihypertensive effect is there, it's going to be sustained for 24 to 36 hours. So basically, if the patient is having a symptom, then if there is a target organ damage, that patient has to be given IV antibiotics. One thing which can easily be given in our setting is nitroglycerin, because beta blockers, IV beta blockers and all, sometimes, especially without experience giving it and all, might be a problem. But as far as the IV antihypertensives, that can be given safely in a primary or a secondary care setting where an ICU monitor is there is nitroglycerin. So only thing is nitroglycerin will have tachyphylaxis, so don't give it for beyond 24 or 48 hours. Try to limit, because we basically want the blood pressure to be reduced in the initial 1 to 6 hours. By the time we start on with oral antihypertensives also, and usually once this nitroglycerin effect weans off, we can gradually, by 12 hours, 6 to 12 hours, all the orally acting antihypertensives will start kicking in. On the other side, someone comes to you with something completely unrelated, let's say an accident, BP is more than 180 by 100. There's no target organ damage. It might be just a sympathetic response also. In such cases, probably we can wait and watch. On the other side, the same patient coming with a history of hypertension, which was relatively poorly controlled. Patient says that all my hospital visits, blood pressure was 160 by 100. That's a different scenario. That's probably a scenario where we can actually hike up the antihypertensive therapy, provided the patient is not breathless, the patient doesn't have any TIA-like symptoms, nor reduced urine output at all.
Regarding the use of this labetalol, can it be used in all hypertensive emergency except left ventricular failure?
Most of the hypertensive emergencies, labetalol can be used, but do it when actually you should have a monitoring device. Sometimes it can cause a very profound. Start with a lower dose. Like even though you can go up till 50 milligram, 25 to 50 milligram. Sometimes, especially if you have manpower issue and all, start with a lower dose. You can keep on repeating the dose.
Okay.
One question is amla or cilnidipine, any difference? Amlodipine or cilnidipine?
Probably not much of difference because like most of the effects of calcium channel blockers are a class effect. Okay. So there are no head-on trials which actually has tried to compare amlodipine versus cilnidipine. Now, if the question is nifedipine versus amlodipine, yes, there's a difference. Nifedipine causes tachycardia, and some scenarios we don't really want the tachycardia part. Little bit of adverse effect profile might be different, but otherwise, what matters is whether there is a cardiovascular benefit in long term. Probably there are, I don't really think that type of data is there.
Is Lasix can be used in acute elevated hypertension?
In pulmonary edema, okay? In pulmonary edema. Otherwise, it doesn't have a role. Someone presents with a hypertensive pulmonary edema, you have to give diuretics. So we give diuretics, we give morphine. Nowadays, morphine is very difficult to get because of all this abuse and all. So nitroglycerin along with the furosemide. But otherwise, there's no role.
What is the age group to start screening for hypertension?
Opportunistic screening is advised. Like, see, now the problem is there is no screening recommendations for adolescents and all. But now adolescent hypertension is also going to be a big problem. So after 40, annually once, you have to check your blood pressure. And less than 40 years, once in 3 years. And whenever the patient comes to you for something unrelated, screen the blood pressure.
Okay, another question is, in our dialysis unit, while undergoing dialysis, most patients have BP in the range of 190 to 110. Do we have to do something for that?
Yeah, that's actually like a very complex question, and I had intentionally left out. So there are so many things that actually contributes to hypertension in dialysis. First and foremost, we need to see there is something called the dry weight. Dry weight is a scenario where the patient is not having volume overload and the patient is neither volume depleted, like the way someone like us with a normal kidney function is. So most of the time, it's very difficult you have to change the dialysis prescription. You have to see whether the patient is at the dry weight. You have to alter the dialysate sodium. So there are many things actually that is inherent to the dialysis prescription. You will have to see how much is the patient's interdialytic weight gain and all. And generally, especially this in centers where nephrologist is not there, these patients have this habit of asking for, like they come with, Dr. Remya has given Dr. Remya, I would like to have a question. Have you ever looked at how much is the interdialytic weight gain and ultrafiltration in these patients with hypertension? Can you unmute yourself and answer me?
Good evening, ma'am.
Yeah, good evening. Yeah. How much is the interdialytic weight gain and what is the usual ultrafiltration you keep for this patient?
Ma'am, I have not went to that detail.
Okay. So see, at least what you can tell from your side is you have to restrict the salt intake. Like the way this is very strict about CKD patients. You have to cook food without sodium and do not take anything from outside because, for example, the bread we eat that contains quite a lot of the modern bread we get that contains quite a lot of sodium. So do not eat anything from outside. Eat only home cooked food. Make it without salt. Take one level teaspoon of salt, and that's what they have to consume in a day. And that's one of the most common reason. The other thing is, if they have a huge interdialytic weight gain and you are trying to remove that interdialytic weight gain, usually they develop hypertension, but sometimes some patients develop reflex vasoconstriction also. Then the other thing is whether the efficiency of the dialysis. You will have to see how much is the single pole KT by V of each dialysis session. So usually this is inherently linked to what the patient eats, and the more important is how good your dialysis prescription is. Once actually sufficient ultrafilter fluid removal is there and the patient gets sufficient dosage of dialysis, it's very, very uncommon to have, like you might still have an occasional patient with a very bad blood pressure. But if a lot of people are having this blood pressure, you will have to see. Maybe another thing you can do is you can actually do something called an isonatremic dialysis, where you keep the dialysis sodium within 2 milliequivalents of the patient's serum sodium. For example, you have a patient with a sodium of 132 and you are keeping the dialysate sodium as 145. Then the patient will be gaining sodium, and that will be the reason why the patient will be having hypertension. So you can, if you have a nephrologist attached to your unit, you can actually ask the nephrologist to see the dialysis prescription of this patients. And without a nephrologist, it might be pretty difficult and sometimes might be hazardous also to modulate the dialysis prescriptions.
Thank you, ma'am. But most of them are not taking their medicines in that day of dialysis. So should we ask them to take?
That's actually. See, basically, you are not supposed to skip the antihypertensive. You are supposed to skip the vasodilating medications only. And of all the drugs which is available, so for example, if the patient is on labetalol, fine, the patient can skip. Patient is on hydralazine, the patient can skip. But AC inhibitor and ARB, they don't really need to skip that. That's another big mistake done by our patients. Like they don't take the antihypertensives before the dialysis. You have to tell them to take the usual antihypertensive. Prazosin, you have to skip. Maybe labetalol also. Only those antihypertensive with the vasodilating properties.
Okay, thank you so much.
Madam, regarding the use of hello.
Hello.
Doctor Parnolo.
Madam, regarding the use of antihypertensive in special situation, for example, in diabetic patient with hypertension, it's better to give this enalapril, like
AC inhibitors or ARB.
Madam, my question is that there are definite criteria for this giving hypertension in special situation. My question is that regarding alteration from this special situation and alteration from the general point of view, how does it affect? That is a professional question, not general public.
No, see, basically, okay, one thing is, see, eventually why we treat patients is we want to reduce the blood pressure and at the same time we want to improve the cardiovascular outcomes. So regarding AC inhibitors, even if you reduce blood pressure to the same extent by another drug, your BP might be comparable, but in the long term, these patients who are not on AC inhibitors and ARB, they are going to die early or they are going to develop a major complication. So, CKD, there is no, obviously, none of you might be dealing with advanced CKD, like CKD stage 4 and CKD stage 5. They are going to the nephrologist and they should be going to the nephrologist because a lot of things should be there. But in patients with reasonable GFR and all, do not hesitate from starting AC inhibitor or ARB. The only thing is, you need to recheck the creatinine around a week later and subsequently after 1 month. I told you 30% creatinine increase can happen with initiation of AC inhibitor therapy or ARB therapy, and that's perfectly normal. As long as it remains within 30%, after some time, that's going to come back to normal.
Regarding
and hyperkalemia is generally not a concern if the patient is, unless the patient is on potassium sparing diuretics. It's a concern in patients with a kidney disease, but probably not the type of patients who comes to the primary care or secondary care.
Regarding the endocrine conditions, this any problem with specific otherwise using?
No, that's endocrine condition. So that's a controversial thing because one thing is primary aldosteronism is fairly common, way much more common than we anticipate. So Some guidelines suggest screening of every newly diagnosed hypertensive for primary aldosteronism, and some guidelines suggest that you should try with the usual antihypertensive. For example, if it's primary aldosteronism, what it takes is some spironolactone or something belonging to the same category, and whatever remaining drugs you give, the blood pressure is not, you give calcium channel blocker, nothing will happen. The blood pressure is not going to come down. So some professional bodies asked to screen, try the usual antihypertensive and screen only if they fail to work. So as of now, we don't really have evidence, but what I would suggest is it's costly, and sometimes interpretation issues also might be a problem. You should not be putting the patient on certain drugs for anything which actually interferes with the renin-angiotensin axis. You can't put the patient on diuretics. You can't put the patient on AC inhibitors and ARB. So probably you'll have to put the patient on some calcium channel blocker or some other agent, and then you will have to do the renin-angiotensin ratio. In our setting, probably screening everyone might be kind of a little bit difficult because it might not be cost effective. So what I would suggest is, suppose a newly diagnosed hypertensive, if the blood pressure doesn't come down with the usual antihypertensive therapy, maybe it's better that you can screen. But again, do not do a CT because there will be a lot of incidental adrenal masses, and it should be the blood test followed by imaging, not other way around.
Regarding the use of hydralazine, earlier days, hydralazine was used in
Hydralazine, the problem with hydralazine is reflex tachycardia. See, for example, someone having a cardiac issue, having angina and accelerated angina and hypertensive emergency. Obviously, hydralazine is not the drug of choice. The similar thing is then somebody with kidney disease and severe anemia, neglected kidney disease coming with a very bad hypertension and anemia, that's sufficient enough to precipitate pulmonary edema. So that is the issue. So if the scenario developing a reflex tachycardia is not going to compromise the patient's clinical condition, probably you can give hydralazine.
Okay.
Management of hypertension in the case of drug defaulters.
You have to see, basically it's their choice whether to live with hypertension or whether to die because of hypertension. It's 100% the patient's choice. So basically you have to counsel them, educate them.
Madam,
and the other thing is actually give a fixed dose combination rather than asking them to take 2 or 3 medications multiple times. A single fixed dose combination probably might be beneficial. But if I know there are certain people who basically doesn't bother. Nobody can help them probably.
Madam, moxonidine ഒരു ക്ലോണിഡിനേക്കാൾ അഡ്വാൻറ്റേജസ് ആണോ? അതൊന്ന് പറയോ?
It actually, clonidine sometimes produces very bad CNS adverse effects. Patient might be depressed, patient might be sad and all. Moxonidine doesn't have that much of, it's not that much of a problem compared to clonidine. So sometimes patient will have the classic description of patient പറയുന്നത് തലക്കടി കിട്ടിയ മാതിരിയുള്ള ഒരു ഫീലിംഗ് ആണ് ക്ലോണിഡിൻ 2 ടാബ്ലറ്റ് 3 നേരം കഴിക്കുമ്പോൾ. So moxonidine, some somnolence might be there, but it's not as bad as clonidine.
എറിത്രോപോയിറ്റിൻ ഇഞ്ചക്ഷൻ എടുക്കാൻ പേഷ്യൻസ് വരുമ്പോഴേ ഓൾറെഡി ഹൈപ്പർടെൻസീവ് ആയിട്ടുള്ള പേഷ്യൻസ് 180 എബോ ഒക്കെ കാണുന്നുണ്ട്. പക്ഷെ നമ്മൾ സാധാരണ എറിത്രോപോയിറ്റിൻ എടുത്തു കഴിയുമ്പോൾ വീണ്ടും BP എലിവേറ്റഡ് ആകാറുണ്ടല്ലോ. അപ്പൊ എന്താ ചെയ്യേണ്ടത് അങ്ങനെയുള്ള ഒരു സിറ്റുവേഷനിൽ?
So I have intentionally left out blood pressure management in advanced CKD. I believe actually these patients might be having severe kidney failure, right?
അതെ, അവര് ഡയാലിസിസ് ചെയ്തുകൊണ്ടിരിക്കുന്ന പേഷ്യൻസ്
not something that you can manage. That's something which is actually 100% in the nephrologist domain. So you can't actually do much for this patient. This patient needs to be referred to back to the nephrologist for blood pressure control. You can take erythropoietin. You can take erythropoietin. And mind you, the CKD patients, they tolerate blood pressure way much. They tolerate very low hemoglobin and very low blood pressures way much more better than anybody else because the system is quite attuned to that. So that's not a uncontrolled hypertension. Is like a blood pressure of 180 by 100 is not a contraindication. You can give erythropoietin, but always advise the patient go back to the nephrologist and control the blood pressure. Maybe you can add a calcium channel. Yeah.
Okay. Which stage of CKD treatment is to be started? ചോദ്യം എന്താ ഉദ്ദേശിച്ചത്?
That's okay. Hypertension. If it is hypertension, the CKD definition is a sustained albumin creatinine ratio of more than 30, documented over a 3-month period, or a GFR of less than 60 ml. Again, documented, persistent over a 3-month period. And then there are other situations. So let's say the patient has polycystic kidney disease. You should have some imaging abnormalities or something like that. So, if the patient has CKD and if the patient has an elevated blood pressure, irrespective of the stage, we have to treat it. Even if the patient, see, for example, the patient will have a GFR of 90 with a urine AC ratio of 100. And if that is persistent, that's an indication that CKD only, and that has to be treated. So it's not really based on the stage. And if the patient satisfies the definition of CKD, you have to treat.
What is the average half-life to develop hypertensive glomerulosclerosis in an uncontrolled hypertension?
Uncontrolled hypertension, okay, so like we don't really have experimental data, but it takes like a few years. It's not that actually somebody had a hypertension diagnosed last year and coming this year with with a kidney failure. It's very likely that the kidney disease was the reason for hypertension. Hypertensive nephrosclerosis usually develops after a decade or two of poor blood pressure control.
How to
Because
manage
usually essential hypertension, actually it starts off with you'll have that elevated blood pressure for some time, then your BP will be 140/90 for quite some time. So after 4 or 5 years, it might become 150. So that progress is quite slow. That will be reflected on the kidney. And generally, like essential hypertension transferring rapidly to this so-called malignant hypertension, that's not at all common in our patients. Whereas it's very common in black races, not in South Asian races or non-black races, it's uncommon.
How to manage young hypertension?
Young hypertension, always you should look for secondary causes. So under 30 years, developing hypertension needs extensive evaluation. So at least what you can do, a basic evaluation is you can actually look for the renin-angiotensin ratios, an ultrasound kidney function. Kidney function anyway has to be done in all hypertensive. And if all of this are normal, probably you'll have to refer the patient to a specialist because this needs a lot of extensive workup.
What's the maximum dose of Arcamin in CKD?
Yeah, we go. The textbook says 1,200, but patients will be walking like a zombie if we go for 1,200. So I give sometimes up to 900, but like I'm not a big fan of Arcamin. And in my opinion, if you titrate the other things, probably you can actually you need not increase to that high doses.
Any role for sublingual nifedipine or captopril as per new guidelines?
No. Because basically the idea is you should be able to titrate. If you shut down the IV drip, the advantage of IV drip is you'll be able to shut it down. So there's no role for sublingual nifedipine or captopril. And by the way, captopril is not available also. I think actually for the last couple of years, it's no longer available.
Questions തീർന്നു.
Okay.
Ma'am, excuse me, ma'am.
ഒരു ചോദ്യം വരുന്നു.
Ma'am, it's not something related to hypertension, but I'm actually a physician working in a Taluk hospital in Kerala. So we have a dialysis unit and we are seeing, many complicated cases, I think. So can you suggest any short handbook of dialysis for us so that we can...
if you are interested, there's a handbook of dialysis called Dogirdas. You can note down the name. You can read it.
Okay, ma'am. Thank you.
It's written very simple because that's the first book that we advise our DM trainees to read once they come to nephrology. Okay, so I believe actually it might be a little bit of effort because especially you don't have anyone to guide you, but still it's written in a very easy language.
Thank you so much.
Madam, does we have to go to a maximum dose of a single medicine, then add on another drug,
Yeah,
and we can, or we
so
can add two drugs in the
no,
same
it's not.
lowest dose.
It's not recommended to go for. So it's not a stepwise approach. See, for example, there is something apart from the antihypertensive half-life. There is something called a peak to trough ratio. So basically, like when we take the antihypertensive, our blood levels goes up, and when actually we are about to be the next dose, the blood levels are going to be fairly low. So usually this peak to trough ratio, it should not be less than 30% of the peak values. The trough values should be ideally, the lower the ratio, the greater will be the sustained antihypertensive activity. Now, when we give two drugs, so let's say one scenario where actually the drug is there in the system for around 20 hours, and in the remaining 4 hours, it goes actually less than 30% of the peak values. The person is not having to have optimal antihypertensive effect. Now, if we combine with another drug, it's very highly improbable that both drugs will have the same peak to trough ratios. So even if the ratio of trough ratio of one falls below the recommended limit, the other one will be able to take care of. So you need not actually go to the submaximal doses. Okay, let's say you can start off with one drug, and if everything is controlled with 2.5 milligram of enalapril, then well and good. But on the other side, if you want to add another drug, if your patient's blood pressure is not controlled, rather than making it 5 milligram, it's okay to add another drug to that enalapril. That's either way is okay. And studies have shown that probably this dual combination is kind of better in giving round-the-clock protection.
Thank you, Dr. Priyamvada. Any more questions? If no more questions, we will wind up. I think there are no more questions. Nothing in the chat. So we shall
I think
wind up.
everything is so. Yeah.
Thank you. Thank you, Priyamvada, for sparing the time in your busy schedule and enlightening us. And with this session, we are concluding the hypertension. Thank you once more on behalf of KGMOA and Academic Cell. Thank you very much. Good night.
Thank you. Yeah, good night. Thank you, and good night to all.
Good night to all. Thank you. We are ending the session.